Good afternoon, everybody, and thank you for joining us. My name is Keith Carrington. I'm the Marketing and Sales Director here at Computech City. I'm joined today with Kalyan Kumar, the Chief Operating Officer for Build Right. And we'd like to thank you for taking time out of your busy day, especially the Friday before a holiday weekend, to attend this webinar. We're going to be talking today about how ACA and sequestration will affect your practice. It's certainly a key topic that everyone's talking about right now, and it's very timely, and we hope that you'll find value in this presentation today. A couple of notes about today's presentation, if we can go through on that. If, as we go through this presentation, you have questions, feel free to type those in the Q&A panel that you're going to find in the middle of the left column on your screen where it says Q&A. You can actually type your questions in there, and we'll get to those at the end of the session today. Once we wrap up, we'll go into questions, and then Kalyan will be more than happy to answer the questions that pop in for us today. Additionally, this webinar will be recorded today, and it will be available on our website, and we'll be putting an announcement out as soon as it's uploaded to our website. It takes us about a week or so after we render it down and edit it. We'll get it back up there online for you. So we'll get that message out to you next week and let you know when it's available to view on demand at any point in time. And in tandem with that, I do want to point out that if you've attended presentations recently, either in Prezi or PowerPoint, you know that the general rule is that you try to keep your slides unencumbered, not too much copy on them. Well, we're going to actually ignore that rule for this presentation because there is a lot of technical material that we're going to be covering today. So we've actually gone ahead and actually put it in a summary format in these slides. So you're going to see a lot of copy. Don't worry about trying to read them or trying to take notes if you do, because again, this presentation will be recorded. You can go back as often as you want to see it. And that's the reason why we put the copy as we did on there, so that you can go back later and view it and you can actually read all of that copy. So we'll be talking to it today. Feel free, you don't have to read every word on those slides because again, you'll be able to access it later on demand. With that said, I'd like to introduce you now to Kalyan. As I indicated, Kalyan is the Chief Operating Officer for Build Right, and he's been with the company now for 6 going on 7 years. Is that correct?
This is my 7th year.
7th year, excellent. And Kalyan, all in all, you have almost 20 years of experience in the healthcare
almost
arena,
yes.
correct?
Almost yes.
And your experience has been in building practices and going into an operation, whether it's a practice or a hospital. I know you spent some time in Lubbock working on a hospital project.
Yeah, I was part of the process.
And your experience really is in workflow and back office, in building the processes and those workflows to help an organization optimize its revenue and its efficiencies, correct?
You're right. You're absolutely right.
Fantastic. I think our audience is really going to benefit today from not only the material that you're covering, but also the fact of your deep years of experience here.
It's my pleasure.
Fantastic. Well, Kalyan, you know, the question that I keep hearing when I'm talking with doctors and practice administrators, and I know you get the same question day in, day out from talking to our clients,
yes, I do.
Is what does all this mean for our practice? You know, we're sitting here right now in this transformative period in American healthcare where we've got layers and layers of new regulations. We just heard that we've rewritten HIPAA with the omnibus rule and some of the requirements there. We changed the breach notification rule. And then on top of it, we've got all new rules around billing and collecting. We have ICD-10 that's coming down. And then we've got the weight of both sequestration that kicked in on April 1st of this year with their mandatory cuts. And then we've got ACA that's slowly creeping into implementation in phases. So naturally the question is, what does all this mean? Where do we go from here? And what does it mean to my bottom line? And I know in preparing for today's webinar, you and I have had some time to talk, and I understand that you really want to cover 3 different areas.
Yes.
First, we're going to talk about sequestration's impact on the practice.
Right.
Then we're going to talk about the Patient Protection and Affordable Care Act, also better known as ACA. And then we're going to talk about how you can offset some of those negative cuts through proper optimization of revenue cycle management. Correct?
Exactly. Optimization of revenue cycle management, that's going to be the key.
Fantastic. Well, without further ado, then let's jump right in and let's tackle sequestration, shall we?
Sure.
All right. Now, sequestration kicked in on April 1st after the president signed the bill enacting it. And I know that in March of this year, CMS had put out an explanatory memorandum, and then another one May 1st and May 3rd.
Exactly.
Trying to clarify this, and we're going to go through some of that today. But could you kind of give us the lay of the land and some of that background on sequestration from a Medicare perspective?
Sequestration from a Medicare perspective, it's going to be basically on the reduction, because the healthcare industry is going through a revolutionary cycle where all of these payment cuts and all of these meaningful use and the incentives and all that is going to come in place. So basically this sequestration, it's been there in the discussion panel for almost 2 years, and after all these acts and all that, they had no other option except to make it a mandate by 1st of April 2013, and that's how we have all this. We have all this coming in place at the same time.
I see. Safe to say then that it's a 2% cut across the board on all of the, affecting all of the Medicare plans, affecting all the incentives right now, correct?
It does cover all of the plans. It does cover the Part A, Part B, Part C, and Part D.
Okay, excellent. Well, I think that's the point that we're at, and I think that's the point you're driving home, is that it's going to hit all these plan types. Is there anything else that I'm missing on this?
Basically, say probably a little yes and a little no, because the Advantage plans, the Medicare Advantage plans, normally what we call as Plan C, those are, yes, they are going to be hit. And then we have the prescription drug plans, which are basically pharmacy plans. The Plan D ones, they are also going to be covered in this. We also are going to be affected by the cost plans. Cost plans, people with cost plans coming to practice, getting treated. I know it's not that familiar, it's not that regular a routine, but still, yes, the reduction is going to be there.
I see.
And then we also have the healthcare prepayment plans, and then the PACE plans, which is basically for the elderly people, where it covers all of the medical, social, and the pharmacy part of it.
Okay. Now, the reduction is going to come, from my understanding, on what Medicare reimburses to the physician, correct? For their billed services, and there's a formula that they follow.
Exactly. There's a small kind of a misconception about it. Okay. Basically, what doctors think is like, oh, I'm going to be hit by 2% on my total revenue of Medicare. That's not true, though. Basically, how it's going to be done is it's going to be partially a little calculation will have to be done on that. So the net collection percentage, or plus or minus whatever be the number, that will be reduced by 2%. The final payment made to the provider is going to be reduced by 2%, and the co-payments, allowables, deductibles, they're not going to change. They are going to remain as it is.
I see. Great. Now, I also understand that the Medicare fee-for-service program is subject to the hit as well, correct?
Exactly. Yeah.
Okay. Can you walk me through some of the parameters on what's going to be affected by the fee-for-service reduction?
Yes. All services from 1st of April 2013, whether it's an admit or a discharge or a date of service, all of them, they are going to incur a 2% reduction in all of the Medicare payments. Okay. And this is going to be affecting all of the durable medical equipments, prosthetics, and all of even the bidding programs of the DMEs. It's going to be reduced by 2%.
And I think it's going to cover all medical supplies. So we're talking catheters, we're talking diabetic supplies.
Yes. It's going to cover across the border. It's going to be a total radar that's going to cover everything together at one shot.
I see. Okay. Any other, what about beneficiary payments? How are those going to be?
It's not going to be affected.
It won't be?
Yeah, it couldn't be. The co-payments or the deductibles that the patients have to, or we will have to collect from the secondary insurance, those are not going to be affected.
I see.
Only the ones that's going to be made by Medicare, that's going to be reduced by 2%.
I got it. So let's take a look at an example, because I know when I try explaining this to doctors, they all want to see an example. And I think we've worked out a pretty basic and simplistic one, but you know what? Sometimes the best math examples are the simple ones. So let's just talk about an even $100 claim.
Yeah, let's make it simple.
Let's walk through that one.
Yeah, let's make it very simple and straight.
Okay.
So a doctor, a provider bills for a service with a claim for, say, a dollar value of 100, or probably with their billed amount. The allowed amount is 100. Let's not go into the confusion of billed amount and what they allow.
Okay.
Let's go by what Medicare allows. So Medicare allows a claim at, say, $100. And then this claim is for the initial phase of the year 2013. So obviously there'll be a deductible. Say let's take 50% of it as deductible. So $50 gone. Right. So balance is what is $50, and that's what we have to collect from Medicare and the other insurance.
Right.
Medicare obviously is not going to pay the 100%. Medicare they cover only at 80%. So what's actually we can expect from Medicare is only 40%. Out of that 40%, there's going to be 2% reduction.
I see.
2% of $40 is going to be 80 cents. So if you reduce that 80 cents and $40, the net payment to the provider is going to be $39.20.
I see.
And the co-insurance or the co-payment or the deductible, we will have to fight with the patient, chase the patient, go after the patient, do all measures and make sure that we collect it.
Oh, I see.
Yeah.
So really, it boils down to, in this example, then, if I'm following correctly, really the doctor's going to lose 80 cents on that $40 collectible from Medicare.
Exactly. You're right.
See. Great.
You're right.
Thank you for clarifying that for us.
Fine.
Now, one thing I know that you mentioned a little bit earlier is that the incentive programs, all the federal incentive programs, are also affected. And obviously, right now we have a majority of doctors are going through the meaningful use
Exactly.
attestation. Excuse me. And so they're asking, what does this mean for me? Will I see a reduction in what I'm supposed to get from the federal government?
Oh yeah, they are going to get a reduction on the incentive payments too. Basically, the reason as to why they brought in all these incentive payments is initially they are showing up, the federal government is planning to show an incentive with a higher number, gradually decrease it the next year and keep on decreasing until it reaches a point where it's going to be zero. And at that point, all the providers will have to qualify for that.
I see.
If they don't qualify, that's going to be penalty.
Ooh, okay.
So obviously there's going to be a cut in the incentive programs too.
see.
The electronic hospital records, the prescription drugs, meaningful use, all of them, they are going to be covered in this.
I understand. That's so we are going to see some significant cuts there coming
Sure, coming on.
Well, we've kind of gotten into the broad strokes on sequestration and
Oh yes.
and its impact from the Medicare payment side and from the incentive side. If we can, let's go ahead and transition over then, and let's talk about ACA.
Right.
I was talking with the doctor the other day, and it's probably the best analogy I've heard yet about that piece of legislation. He described it as an onion, saying, when I look at ACA, it seems to me like it's an onion, just layer after layer after layer of new requirements, new changes, enhancements. There's what we have to do as an employer, noting that, medical practices are employers too. So,
Yes.
He has to peel away that layer of the onion to understand what do I have to do in terms of offering health care coverage to my employees as a small business. But there's also the billing and collecting layer, and there's the Medicare and Medicaid changes.
Yes. Oh yeah.
Then we've got compliance programs and some compliance requirements that are going to have to be in place for providers if they collect Medicare.
Yes.
Then we've got this new introduction of value-based payment systems, changes to PQR initiative.
Yeah. All the
So for doctors who are trying to peel these
Onions.
onion layers away and make sense of this legislation, keep in mind most of them haven't gone to law school. They're not politicians by trade.
Right.
They're in the practice of healthcare. So it gets really confusing, and it's very easy to get some misconceptions. So I'm hoping that you can not only walk us through some of those layers of the onion, but maybe
Sure.
clarify some of those misconceptions for us.
Sure, I'll be more than happy to do that.
Fantastic. Well, let's dive right in. And you know what? If it's all right with you, I'd like to maybe jump in and let's get the employer perspective covered first, shall we?
Looking at it from the employer's side. Looking at it from the employer perspective, so far employers would have had the option of either having an insurance, health insurance for their employees, or probably trying to buy some kind of a small plan, getting associated with them and going on with them in that way. That way the benefits or the healthcare limitations were more. So taking all that into consideration, the ACA, what it does is it's going to bring in a kind of a mandate where everybody is going to be little insured as far as the healthcare domain goes. So employers will have obligatory responsible, will have to be a little more responsible, meaning they will have the obligation of providing healthcare insurance for all their employees, and that's going to be overhead on their monthly expenditure.
I see. So moving on then, from the employer side, and I realize as questions come in today, we'll go ahead and field those at the end of it. So if they've got some employer-related questions, we'll try to tackle those at the end as well.
Sure,
correct?
sure,
Excellent. Let's transition over for a minute if we can. Let's talk about the billing and collecting side. I know there are some new patient benefits provided under ACA that's going to, change the landscape and require
Exactly.
some knowledge of those changes in terms of how the medical office staff is advising patients on financial responsibilities. So I was hoping maybe you could walk me through that. I understand there's some
Sure.
no copay, there's copay reductions and some lifetime benefit changes,
There,
right?
there are going to be changes in looking at it from the billing and collections perspective too. Basically, so far we would have encountered a scenario where there would have been a pre-existing conditions and claims would have been denied, and then we will have to go behind the patient and trying to collect the money. But from now on, gradually that will decrease and come to a point zero, where no pre-existing condition would be allowed, meaning all individuals will be given a health insurance plan
Okay,
irrespective of whether they have any kind of a pre-existing condition or not.
I see.
So that's going to improve a lot. That's going to be a little easier from the billing and collecting perspective. And then not going to be any kind of a limitation. Lifetime maximum, annual maximum, all that is going to be removed off the books.
I
And that's
see.
not going to happen immediately. It's going to take its due course of time.
Okay,
And these are two good things. And apart from that, we are going to have a scenario where we need not collect the copay, deductible, and all that upfront, making sure that the patient has paid and all that. The headache of trying to collect money from the patient when they themselves are not good, it's little less. And those additional burden is going to be borne by the insurance companies.
I see. Um, so, in other words, then we're going to have some no copays or deductibles, correct, for the preventive services?
Exactly, exactly.
And that's going to be on the commercial and HMO plans, correct?
You're right. You're right.
Okay, perfect. Moving on then, let's talk about Medicare and some of those changes.
Yeah.
What can you tell me there about the changes we can expect to see?
As far as the Medicare is concerned, say the preventive visits, they are going to have a lot of the existing cuts, a lot of these existing acceptance and all that. That's going to slowly go away.
Okay.
And a lot of the current day headaches that we have, it's going to slowly go away. And primary care is going to be motivated more, meaning providers who provide primary care, they're going to have a kind of a 10% bonus on an annual basis.
I read that, and that's for primary care. That would include your internists, correct? Family
Sure.
practitioners.
It does.
Okay,
It does include all the internists and the family medicine practices,
great,
internal medicine practices.
fantastic.
So those are some certain good changes that's going to come in. And apart from that, we are going to have additional bonus payments to be made for doctors who provide services in the healthcare professional shortage area,
I see.
the HPSA category. So those areas they are going to identify based on zip codes, and then those doctors who provide services in those areas, they are going to get a 10% bonus too.
So there really is some opportunity for revenue growth or some
Exactly.
incentived revenue, which I'm happy to hear, and I think I'm even more pleased to hear that it's really focused on the patient care. And I think that's been one of the big concerns is that will ACA distract us from patient care? And at the end of the day, I think every doctor agrees, don't tie my hands. I want to be able to provide for my patient. So
Oh yeah.
it sounds like again, what our doctor was telling us the other day, I'm peeling this onion and I don't understand it. I'm losing money here, but there may be some opportunity here for some offsets, and it really gets confusing, doesn't it?
That's the reason we initially spoke about revenue cycle management process,
Mm-hmm.
the compliance measures, how to navigate around it, how to offset these payment cuts through the other ACA and the other bonus payments that we are going to get. It's going to be a little tricky how we navigate, how we plan. It's all about that's going to be the key point.
Excellent. Well, let's jump over. I know we talked Medicare, and it seems like anytime we want to tinker on the Medicare side, we got to tinker on the Medicaid side.
Sure, we have to.
So can you tell me about that? And from what I understand, this might be some good tinkering on this side, right?
Yeah, a lot of changes going on from the Medicaid side.
Okay.
The providers they are encouraged to provide maximum health care
Mhm.
on the primary care area, and
Okay.
those providers who provide all of the face-to-face visits with the patients,
Mhm.
the evaluation management procedures, if they perform those procedures at up to a threshold of say 60%, then they become eligible for self-attestation. And once they do the self-attestation, they get paid on par with Medicare.
Understood. Now, there's some deadlines coming up very close, right,
Yes,
for that self-attestation?
Yes, that deadline is very, very close. May 31st is the last day for that self-attestation for the state of Florida.
So a week from today.
A week from today.
Okay.
Meaning they can do it. They can do it after June. They can do it in July. They can do it in August, September, anytime. But the only thing is, what's going to happen is the day on which they do the self-attestation, only from the first of that month, the increased reimbursements are going to come in.
I see.
But if they do the self-attestation before 31st of May, the increased reimbursement is going to come all the way back from January 1st of 2013.
I see. So if the doctor completes that attestation by next Friday, a week from today,
Exactly.
they'll be able to get that increase
Right from
retroactive from January 1st.
1st of January 2013.
As opposed to if they wait till June 1st,
No.
they're only going to get June on, or the first of the month in which they attest,
Exactly,
correct?
exactly. Not only that, this is going to cover the secondary payments of Medicaid too. So far,
really?
most of the practices, what would have happened is they would have got denials from the secondary Medicaid, saying that the primary paid more than secondary allowed. So they are going to deny those claims.
I see.
Those claims are not going to be denied anymore. They are not going to be paid. They are going to be paid.
They will be. Okay.
And those claims, at a one shot, Medicaid is going to take those claims for a reprocess, one-time reprocessing, and they're going to do it in the month of June. And all those payments they can expect to come in by, say, June, July, August.
Okay.
Yeah.
So they'll get a little help there as well.
Yeah, the cut from the sequestration is going to be offset by this, but they will have to be a little more vigilant.
Right.
Yeah.
Okay. Now, this particular segment is always near and dear to my heart. Not so much to our clients. I usually get a lot of groans and a lot of eye rolling from them. And that's the topic of compliance. I understand we've got actually quite a bit here. So I think we've broken it down, if I'm not mistaken, correct, into 3 parts on the compliance piece we're going to talk on this morning.
Exactly. We need to have.
Okay. Well, then let's dive into part 1, shall we, and talk about some of those compliance changes they can expect.
Sure, definitely. Normally, as of now, what physicians would do is whenever they have a kind of a patient to be referred for a CT scan or a MRI imaging or something like that, they either send those patients to their partly owned centers or fully owned centers, and those kind of things are still happening. To put a cut on that aspect, there are going to be new regulations coming in place. New regulations is going to be a little more vigilant, little more aggressive. They are going to look at all these scenarios from all different angles and make sure that those physicians are not part of that ownership.
Okay.
And if there is any kind of a violation to it, obviously it will be caught.
Sure.
So just to make sure that if there are any providers who also own a kind of a CT scan or partially owned,
they have to disclose that now up front.
Disclosure is the best recommended mode.
Okay.
That's the best methodology.
Excellent. I also think there's some prohibitions, correct, on new ownership investments in acute
Exactly.
care
No, even if they are planning to own, it has to be disclosed.
I see.
Disclosure is the best.
Okay. And there's I guess this all goes back to Stark violations, correct? That they're trying to curb that because they know that's become a rampant issue in some parts of the country.
Issue. Oh yeah, that's becoming a rapid issue.
Okay.
And Department of Human and Health Services, that's keeping a very cautious eye on it.
I know I read a bulletin out of Health and Human Services last week from one of their listserv message boards that had indicated that once this kicks in, the OIG, the Office of Inspector General for HHS, is intending to pick up on what they call a SNAP audit, which is going in and just randomly auditing or posing actually as a patient and seeing if they're getting.
They are going to try it from different sources, not just as a patient. Can be from different sources, and they are very, very, very keen on it.
Okay.
Very specific on it.
So doctors really need to, and office managers really need to pay attention to some of these details that are coming down, and just really take a look back. Hopefully they're already doing the disclosure like they should be.
Exactly.
But if they're not, then they've got to get started.
It's better to do it.
Okay. Well, let's jump into the second part then of this. I know that this has to deal with some claim submissions, correct?
Okay, I submit a claim.
Mm-hmm.
and then tomorrow they find it out that it's a kind of a kickback.
Mm-hmm.
Obviously, they're going to have an anti-stickback statute and throw my claim back. It's going to be a false claim. They're going
Okay.
to return it back. They're going to ask me to pay that money back within a specific duration of time, as otherwise they're going to recoup my money. That's
Okay.
it. Looking at it from a provider perspective, I would say that.
Yep. Now, they've also imposed some timeframes on claim submission now,
Oh yeah.
correct?
No, we had it. I think we had it about a couple of years back.
Oh, we did.
We have
Okay.
been having it for the past 2 years.
Okay.
Claims for all Medicare, Medicaid, they have a ceiling of 1 year filing limit.
Calendar year, right?
Or 1 calendar year.
Okay.
Yeah. Oh, yeah.
Fantastic. And then the overpayments you were just talking about, I think if I'm not mistaken, they've got 60 days to return that money.
Oh
for
yeah.
overpayment.
Otherwise, it's going to be recouped.
Okay. Excellent. And now I was hoping maybe you could spend a couple minutes and talk about the required compliance program provision in ACA that impacts Medicare providers. Could you talk about that for a minute?
There are a couple of things which providers definitely will have to do. Meaning, if someone is going to join a new group, or the group, looking at it from the group's perspective, is if they are going to add a new provider to the group, existing group, there are a lot of compliance measures to it. Meaning, the individual doctor who is going to join that group will have to have his own compliance measures in place, making sure that he's following all the regulations, the meaningful use, EHR, ERX, and all that has to be followed. And the group should also be following. And then there has to be a final kind of a compliance measure from the group side to make sure that all the individual doctors in that group, they are under the compliance program.
I understand. So if you want to add a new member, if you're going to form an ACO, you're going to any kind of merger, any kind of business change within that
Any
practice
kind
is
of
gonna
merger,
require it.
acquisition, or anything like that, it has to have all compliance in place, all
Okay.
compliance regulations in place,
Great.
and both from the joining side and the accepting side.
I see. Okay, and I know we will probably have another webinar near the end of this year, probably
Oh.
later this fall, where we're going to talk more in depth about compliance programs.
Sure,
We're gonna
we
talk
should do
about the omnibus compliance as we get close to that. So
That's
I'm
what.
sure we'll touch on this and go into more detail at that point.
Sure.
So, moving away from the compliance piece for a second, let's spend a minute talking about value-based payment systems. And that's a new introduction through ACA.
Yeah, it's basically looking at it from the pay by performance perspective.
Mhm.
So it's going to be denoted, and it's not, as of now, it's not in place. It's going to be coming into effect from the year 2014 and thereafter. So it will have to be denoted by a modifier that's going to be submitted in the claims.
I see.
So
Okay.
these are certain good things which is going to make life a little more easier, because once we have things in place at home, and then when we report it to the insurance that we have things at place, it's going to make life a little more easier.
And these modifiers are going to start getting reported in 2014, correct? So next
Exactly.
year?
From next year, and from there on, it's going to be kind of a rule.
Okay.
It has to be a guideline.
And I understand they're running a pilot program
Oh
to-
yeah, that's
to
going
be
to be
able to match to track tie the payments to episodes of care, correct?
Exactly. One episode of care will have to be tied to that particular category, meaning a patient getting discharged from a hospital cannot be seen within the 30-day duration. Some kind of regulation is going to come in place.
Okay.
And all that is going to take shape, and it's going to be finalized by the year 2014.
Excellent. Well, if we can, let's talk for a second now about PQRI. And I understand there's some changes to that initiative that are being done through ACA, correct?
Yeah, as I was telling you before, all these incentive programs, initially it's kind of a carrot that they show you before. And
Sure.
as you closely go into it, it starts going down in size. So earlier we had a little more higher percentage on the PQRI and the other incentive programs. They started reducing that a little. That way, 2012 to 2014, we would have had 1% in the year 2011. 2012 and thereafter, it's going to be one half of 1%, which is 0.5%. So 2014, from there on, we don't know what's going to be. Might be 0 or maybe 0.25%. We don't know. So
see.
it's basically these quality reporting initiative and all that the healthcare industry is aiming to force the provider community into.
Mm-hmm.
It is basically a drive to focus them or more on the primary care and make sure that there are quality resources and quality initiatives in place.
I see. Okay. Now, I know we've briefly gone through this, and we could probably spend a couple of days talking about all
Oh
of the
yeah,
aspects of ACA. So clearly, there's no way we can get it in what would be a 30 to 40-minute webinar,
sure.
like we're shooting for today. So you know, by no means I think we're only scratching the surface of this
Exactly.
and talking in
Exactly.
generalities. But as we do, I'd like to talk. I know there have been a number of misconceptions expressed out there within the community, and
Oh,
I
yes.
think even outside of the healthcare community, I think the American public, I think, has a number of misconceptions about it, good and bad. And it's certainly not a political issue, and it's not which side of the fence are you? Are you red or you a red voter or a blue voter?
Oh,
It
yeah.
really comes down to just let's take a look at some of the misconceptions about the actual workings of ACA. And I know that there are three big ones that I keep hearing are that ACA is going to do away with employer-sponsored health
No,
plans,
no.
right? And that's not true, is it?
No, the biggest one that I've come across is ACA is going to completely change the way Medicare, Medicaid operate. No.
We're not actually tinkering with the actual program administration at all, are we?
Medicare, Medicaid is not going to change at all. All these incentive programs, all the sequestration that's coming into place, it's all to encourage. It's basically a plan to encourage electronification of the process on the overall perspective and make sure the quality initiatives are there in place and complaints are there in place. That way, it's much easier for a revenue cycle management to run on its own as a cycle without wasting too much of money, obviously.
Certainly, right. Now, I've also heard that ACA is going to preempt any state regulations on healthcare professions or on healthcare institutions, that it's actually going to replace state licensing. And from my perspective, I know that's not really the case.
Oh, yeah.
I'm sure you've heard that as well, correct?
Yes, that's not really the case. They don't have to be confused that much, thinking that ACA is going to completely alter the way state Medicare or Medicaid is operating. So they don't have to be worried about it.
Excellent. So then, just to recap on this point, if we can, for a minute, bottom line, I think the points that we want to drive home are that ACA is not going to replace the employer-based or individual health insurance mechanisms.
Yes,
They're
it
still
does
there.
Yes,
The Affordable Care Act is not fundamentally changing Medicare and Medicaid.
exactly.
There are changes in terms of processes, in terms of how you're submitting your claims, as we've talked about today.
Exactly.
Ways they're going to treat, new disclosures, new compliance programs. But at the fundamental operative aspect of both of those subsidized health plans, nothing really is changing there from ACA. And then lastly, ACA is not replacing state regulation of the medical practice.
No, they are not going to change any regulation.
Excellent. Well, Kalyan, I appreciate, we've gotten through sequestration. We've talked about those cuts.
Oh, yeah.
And we've talked now for a bit on ACA, and I think we can all agree, well, we may have peeled up that outer shell of that onion, but we haven't. It'd take 2 days of talking to get to the center of that onion. So
that's a big topic.
Can't do it all in the webinar. But what I'd like to do at this point is transition our discussion over in terms of revenue cycle management and how that can help offset and how, if we know we're going to see a reduction in what we get paid.
Yes.
And we have to look at this as a business, correct?
Yes.
And in Business 101 says, if you have diminishing revenue,
yes,
you have to look, if you want to grow your practice and if you want to grow your revenues, but
Yes.
you're getting decrease in payment, then what you have to do is you have to look at the efficiencies, and you have got to introduce greater efficiency into your practice.
yes,
And you have to make sure that you're capturing all of your revenue or the most revenue possible. You don't want any revenue leakage
sure.
on the other side.
Sure.
And I think that's true on the revenue cycle management, that's one key area that we look at and we often take for granted in the medical practice. And, after a while, we just kind of assume this is the best it can get. And,
Yeah, that's not true,
I'm
though.
surprised. I talk with doctors a lot, and, they'll tell me, well, I'm collecting about 70%.
Oh my God, that's too
They're
less.
leaving a lot of money on the table at that point.
Oh,
And for some of them, they're going, yeah, but you know what? It's been that way. I don't know how to get more out of it.
oh
And
my
so
God.
what I'd like to do is, and I think you put together a quick billing assessment, but
Oh
really I
yes,
think the message we want to get through to our attendees today is that if you can reduce the negative and optimize the positive of what's coming through sound revenue cycle management. You had kind of alluded to this earlier when we were talking about the bonus payments for primary
exactly,
care physicians
right.
and general surgeons, that you know what, you really need a good, strong billing partner who
Who
understands
knows?
this, who has the resources to really track all of the changes and track where there's opportunity for money, as well as being able to step back and being that third party neutral set of eyes to say, hey, there are some inefficiencies here and we need to improve those.
Right,
Would you
right.
agree?
Of course, I have to. In fact, that's the truth. Because without regular compliance audits in place, without ongoing compliance measures in
Mhm.
place, without quality initiative and all that in place, it's going to be too difficult. It's not going to be that easy for a medical practice to run on. Keeping in mind the overheads that they are going to have by way of running their practice and incurring additional expenses on insurance and all that. And apart from all that, they're going to have, on top of all this, they're going to have payment cuts coming in. And payment cuts not only on the payments, it's going to be on the incentive too.
Mhm.
So, of all this, it does trigger an audit.
Okay. Well, I think we've got a tool that we want to share with our audience today,
Sure, we
correct?
need to.
And we want to talk about a very quick self-assessment that every one of our attendees who's watching this webinar today or may watch it online after today, there's a series of questions, and I think we've got 6 if I'm not mistaken,
Oh,
that
yeah.
they could ask themselves. And it's not meant to be a all-inclusive or a thorough diagnostic tool, but it is a quick check to say, hey, look, you know what? If some of even if one of these is out of place, it probably warrants taking a look at your internal billing cycle, your current
Exactly.
billing processes to see if they could be optimized and if maybe you need a partner such as BuildRight to handle that, correct?
Oh, yeah, yes, yes.
So if we can, let's jump through those questions.
Sure.
Um, and if you would, if you just walk us through those and let us know what the practice should be asking themselves.
Yeah, sure. We can probably, the self-assessment can be on the following lines. Do we or are looking at it from the provider side,
Mm-hmm.
looking at it from the running of practice side, do I have a collection rate that's more than 93%? I mean the net collection rate.
Mm-hmm.
Okay, that's step number one. If I'm 93 and above, okay, I'm little okay. And then, do my claims pass through uh, the clearinghouse and reach the insurance 99% out of 100 times? Okay, step number two, I'm good.
Why is that so important? I keep hearing about the first pass clearance rate. Is it a timing issue? Is it that it's going to slow the claim down and you're not going to get the money as fast? Or what's the importance behind that?
There are little tricks in it.
Mm-hmm.
There are little catches in it. The first catch I'll just share with you. The
Okay.
first catch is once you have your claim in place with the insurance in time, definitely your claim cannot be denied in future for filing limit. That's one.
Got it.
That's number one. Because a lot of claims they get denied for filing limits, especially with HMOs, commercials, and the insurances like that, which have a kind of a low filing limit as less as 60 days. So those kind of issues can be off the books if we have a better submission percentage.
I see. Great.
And then if those claims reach the insurances, say 99% or 99 times out of 100,
Mm-hmm.
then the revenue that's going to come in within the first 30 days would approximately be 80%. You can be rest assured about it.
Okay, so then it sounds like the third question they need to be asking themselves is, am I collecting at least 80% within 30 days of filing?
Oh, yeah.
Okay, so a medical practice should see within 30 days of seeing those patients, you should be seeing 80% of the revenue collected at that point.
Within that 30 days, within the first 30 days. The
Okay.
balance 20%, it's obviously, we cannot say anything about it right away because anyway, that's part of the co-insurance or the co-pay.
Sure, or it's applied to deductible, and now you're going to have to
Yeah,
go invoice
yeah,
the patient
yeah,
again. I
yeah,
see.
yeah. They can also do an assessment in terms of self-assessing, saying whether they remain compliant in terms of all the quality initiatives and all that, and then they can do a self-audit on whether they are ready for the ICD-10,
Right.
because anyway it's going to come in October 2014.
It sounds like both of those are rather substantial
Very important.
undertakings, and I would assume that for most, particularly smaller medical practices that have very small billing staff, maybe
Yes.
one person, maybe it's the spouse of the doctor, who handles the billing, or you've got
Oh,
one
yes.
person and the office manager who pitches in and helps. It's a lot because it takes a lot of time just to get your hands around and get a thorough understanding of all the compliance requirements, especially right now with all the changes. And then having to understand and implement ICD-10 changes. That's quite a lot. And it would seem to me that most small practices would probably benefit from engaging a third party to help them with that, as opposed to trying to take all that on themselves.
Sure, ICD-10 as it is thought, it's not going to be easy and straightforward.
Mhm.
It's going to drive us crazy. It's not going to be easy, straightforward. It's going to drive us literally crazy. It's not going to be easy.
Okay.
As of now, the ICD codes that we have is around, say, 50, 60,000.
Mhm.
The ones that we are going to get from 2014 October, that's going to be 141,000. That's bare minimum.
Wow.
And there are going to be classifications for everything. Everything is going to be further classified. It's going to be the specific code set would only be paid by the insurance. That's going to be another catch in it. So ICD-10 readiness is the most wanted right now.
Now, and it sounds to me like because we're going to do so much more clarification of the diagnoses through codes,
Oh yes,
that it's going to slow the process down for billing.
exactly.
And that's probably going to last a while because it's, you just said we're seeing such an influx in codes. Good medical coders, they get into a practice, they kind of learn the standard codes that they're using, and they can get those efficiencies. But it took them time to learn that. And now if we're completely rewriting the codes for them, it's going to take them a lot more time again, which means they're going to slow down on processing claims as quickly.
Sure.
Which
Definitely,
means
there'll be slowdown on
they
process.
probably need to throw more billers per provider, correct? And I understand
yes.
BuildRight's come up with a formula that really works for ICD-10
Yes.
in terms of how many billers should be allocated per physician.
Approximately, we allocate about 2.5 resources per doctor, per provider.
Okay.
That way, we are able to make sure that we have our compliance plans in place, we have our coding team in place, we have all the process that are taken care of the right way.
Okay, so
The
then
way
really,
they have to be handled.
so really the question then for the doctors attending this webinar today is, hey, do I have at least 2.5 billers per physician in my practice? And if I don't, if I'm not meeting that number, I may have some resource problems in terms of keeping up with my medical billing, particularly as we get into the later half of next year when everything is starting to kick in.
Exactly. That's going to be a tough challenge for every provider.
Excellent.
So it's better ready to be now.
Right. Well, Kellyanne, I know BuildRight has been working with our clients now for 7+ years in helping them optimize their revenue cycle management and really being able to take that burden out of the practice and say, look, we're here to partner, we're here to help with you.
Oh yes.
And I understand that you've come up with a promotional offer for all of our attendees who are viewing this webinar.
Yes.
And that if in fact, as they're going through the self-assessment, they're saying, you know what, I don't have 2.5 billers. I'm not collecting 93%. I'm not getting my 99% clearance rate, or I'm not collecting 80% of my revenue in the first 30 days. Then I've got cash flow problems, and I've got that revenue leakage, or I'm going to have those problems as as my staff gets overwhelmed. What do I do? So I think it's great because you're offering an incentive rate to get started with BuildRight. Well below market average and well below the cost of even maintaining an internal staff.
Oh yes, we are offering a 2.9 introductory offer, and then that's going to be for a 2-year contract, 2-year commitment.
Right.
And then the 2.9% is going to be for the first 6 months. Thereafter, it's going to be 3.9%.
Right. So basically, then at that point, under a 2-year, if a practice were to sign with BuildRight to do revenue cycle management for them, commit to a 2-year term, which really they should do, because any billing company needs at least the first 6 months just to get in the flow and make sure that everything is happening correctly, make sure that all the credentialing is there, making sure that the billing is going smooth, and then you start optimizing, and really practices need to get 6 months to clear up the old billing, and then start seeing the traction for the new billing. So 2 years makes sense for it. And it sounds like you're being very generous in terms of what you're giving to the doctors. I mean, 2.9% for the first 6 months on what you collect, and then 3.9% for the next 18.
Oh yes,
that's a tremendous savings over what the going market rate is for a billing company. And they're not getting just claims processing with you and your team. They're actually getting all of that support that we've talked about today, talking about how you're going to improve the collections, get them a book, because I understand BuildRight does 93% or better for its clients.
Oh yes.
In which case, you're really able to offset some of those costs because you're collecting more than they were collecting before.
Exactly.
If we pull that money off of the table, they're leaving there. Yes. They're gonna be able to round out some of those cuts. But more importantly, they're going to get a partner who's going to be able to guide them through all of the compliance perspectives.
Exactly.
You're already ICD-10 compliant. All of the billers are ready to go, which means once these changes come in place, you're not going to miss a beat with processing the claims. And
we are not.
If it's done right, which it sounds like BuildRight's been doing now for a number of years, the doctor and their practice will not see a big hiccup. And so it really takes a lot of the tension and the frustration and the apprehension about what's coming. And you can take that off the table for the doctor. They don't have to worry about that. They can truly stay, as they ask, focused on the patient. And that brings it full circle to where we started today.
Exactly.
When doctors are going, what does this mean? I don't have the time or the resources to take care of this.
Right.
I just want to take care of my patient. That's why I got into healthcare in the first place.
Oh, yes.
And so with a partner like you could take a lot of that back office, particularly around the money side, which is important, because if the practice doesn't have cash flow, the doctor's not getting paid, staff's not getting paid, they don't have the money to invest in their practice to meet the needs that they've got. It's a recipe for disaster. So let's keep these doctors funded properly. Let's take that pressure off of them, and then they can deliver that care that they so badly want to do.
Sure.
Excellent. Well, at this point, I want to thank you, Kellyanne. You provided an absolute treasure trove of information today.
Thank you.
I realize, again, we've only scratched the surface, and if we go back to our onion analogy from earlier, we probably maybe have just peeled back a little on that first layer of the onion.
First layer of the onion.
Enough to get eyes to water. But hopefully, what we've done is we've given some valuable information. I think you have. You've given some great information for doctors to get started. We've cleared up some of those misconceptions and added some clarity to what's out there, and what we can expect. And with a good partner like BuildRight, working with the doctor, you'll be able to get through the challenges and some of those pitfalls that you can get caught in over the next 12 to 18 months as these regulations kick in. And lastly, we want to make sure you're not leaving money on the table. And
yes.
I think BuildRight can certainly help with that.
Oh, yes.
And with that said, at this point in time, I'll turn it over. I don't see any questions coming in right now, but, I did have a couple questions emailed to me prior to this from some people who couldn't attend today. And one of the questions was they were hoping you could, and I know you clarified, but let's go back and do it again.
Okay.
Let's walk through the example of what happens. How much are they losing under the Medicare fee-for-service on that 2%? Because again, the question that I got emailed today from a practice was their understanding is that it's a flat 2%. The patient is not going to be paying. The copay is going to be reduced by 10%.
No.
Secondary is as well as theirs, and as we knew it, it's not. So just for the benefit of everybody on here, could we go through that example one more time with $100?
Sure. Say a provider bills a claim for $100. I'm looking at it from the Medicare allowable number. So Medicare allows $100 for that procedure, and out of that, say they allow $50 towards the deductible. So $50 is gone. We have to go and get that money from patient.
Right.
And balance is left is only $50.
But and let me just pause there for a second. That $50 coming from the patient stays $50.
It doesn't go down.
They had to pay you $50 before. They're going to pay you the $50 again, right? So nothing's getting reduced there.
I'll look at it from a different perspective.
Okay.
Okay. March 2013, the allowed amount for a particular procedure, it was $100.
Yep.
April 2013, the allowed amount is not going to change. It's going to remain the same. It's
Got
going
it.
to be the same $100.
Okay.
What's going to be affected? The $100 is going to be taken into consideration. All the co-payments, deductibles, co-insurances will be applied, and the net payment to the provider is what is going to be reduced by 2%.
I got it. And if I remember from our example before, using that $100 example, we're talking about $40 net collectible from Medicare.
Exactly. Out of that 2%.
And 2% of that is 80 cents. So the cut is not as drastic as $2 as some folks are thinking it is on $100.
No, it's not $2. It's just 80 cents.
Okay. Well,
80
good.
cents. Yeah.
I hope that clarifies, and I hope it gives everybody a little pause. I mean, granted, we're talking about not wanting to leave any money on the table, and doctors are here to, they want to get paid for their service properly, and
Yes.
you don't want to leave 80 cents on the table, but thank God it's only 80 cents and not $2.
Exactly.
That's the point to take there. Excellent. The other question that I got, and this is the last one that I have for you, is where we talked about meaningful use incentives getting cut by 2%.
Yes.
Does that apply to all the others
It
as
does.
well?
It does.
So
Unfortunately, it does.
So the basic message here then, to just recap, is if it's a federal incentive program, you can expect there's a 2% cut coming to it because it's a mandatory cut across the board thanks to sequestration. And that those cuts will remain in effect. And this is a point I want to clarify too that came from that second question, and that is that my understanding, correct me if I'm wrong, that the sequestration will remain in effect until the U.S. Congress comes back and actually addresses it.
Exactly.
So it could be here a couple more months. It could be here a couple years where we're going to see these cuts until Congress comes up and actually repeals that through other legislation.
Exactly. Until Congress comes in and steps in and says something or does something to make a drastic change to sequestration, it will be in force. And hopefully before this financial year, which closes by September 2013, if something good happens, October might be a good month.
I see. Well, Kellyanne, at this point, we're coming up on our hard stop. I want to respect our attendees' time. I want to thank everybody for coming today to our webinar. I'd also like to invite you back in 2 weeks from today. We're going to have Dave Patel, the Chief Operating Officer for Computech City, with us. And we're going to be talking about developing a cost-effective backup and disaster recovery solution that works for your practice, that ensures HIPAA compliance, is readily accessible and easy to restore, and affordable for you. And I think this is certainly a timely presentation. The Atlantic hurricane season starts June 1st, so we've got to talk about Mother Nature and all she wants to bear on Florida. And if you follow the news, NOAA just said yesterday they predict it's going to be an overactive season for us. So lots of storms, perfect time for that. But let's also not forget regulators. We talked a little about that today. We'll talk about it again next time. One of the big things coming down the pike is we're going to be taking a look at the quality of your BDR solution. So you're certainly going to want to join us in 2 weeks as we talk about that, and probably a good time that we address it now before it's too late when a hurricane is 72 hours out from making landfall, or the regulator is at your door wanting to take a look at how you handle your BDR solution. So we'll cover that in 2 weeks. I hope you can join us, and watch out on Tuesday for that invite that will come out for that webinar. In the meantime, if you're getting this holiday weekend off for Memorial Day, thank you very much. Enjoy your holiday. If you know somebody in the military, thank them for their service, and have a wonderful weekend. And we'll talk to you again in 2 weeks. Thank you, everybody.
Thank you, friends. Thanks, Keith.
Thank you.